This video reviews the patient care issues associated with BVS 5000 support. If you are unfamiliar with the BVS 5000, please review the system overview, which is part of this training series. Patients on BVS 5000 support will most likely be suffering from post-cardial ventricular dysfunction. These patients separate from cardiopulmonary bypass or become hemodynamically unstable soon thereafter, despite maximal inotropic and intra-aortic balloon pump support. Upon arrival in the intensive care unit, patient will be on left, right, or biventricular BVS 5000 support, and the balloon pump will most likely be removed. The patient may experience bleeding, perfusion respiratory distress, reduced platelet count and function, and third space fluid loss. Successful management of these conditions is necessary to optimize BVS support. Upon arrival in the unit and throughout the support period, hemodynamics should be carefully monitored. Filling pressures must be carefully assessed via measurement of left atrial pressure or pulmonary capillary wedge pressure and central venous pressure. Mean arterial pressure should continuously be monitored, as well as pump flow and beat rate, as displayed on the BVS 5000 console. Continuous monitoring of mixed venous oxygen saturation is also recommended. Record hemodynamic parameters as dictated by hospital protocol. Note that whenever the right heart is supported, thermodilution cardiac output measurements from pulmonary artery catheter will be accurate. The BVS 5000 is capable of providing up to 5 liters per minute of blood flow. Pump flow is dependent upon filling pressure, volume management, and the height of the blood pumps. Proper filling of the blood pump is assessed by monitoring pump flow and by visual inspection of the pump's atrial or top chamber. The atrial chamber should fill completely and immediately empty, as illustrated here. If the atrial chamber fails to completely fill, this may indicate that the patient requires rehydration, that blood pumps are positioned too high relative to the patient, or that there is a problem within the chest, such as tamponade or improper cannula position. Should pump flow decrease, first check the patient filling pressures. Filling pressures in the range of 10 to 15 milliliters of mercury should be adequate. If filling pressures fall much below this range, volume should be administered according to hospital protocol and the clinical situation. If pump flow remains low despite proper hydration, check the position of the blood pump relative to the patient. The top of the pump should be 0 to 10 inches below the level of the patient's atria. Lower a blood pump may result in increased filling of the atrial chamber by increasing gravity drainage. Monitor pump flow for 2 to 3 minutes after changing the height of the pump. Elevated systemic or pulmonary vascular resistance may also adversely affect outflow from the pump. Under such conditions, pharmacologic intervention with afterload reducing agents may be indicated. The clinician should be mindful of potential for cardiac tamponade, particularly during the immediate postoperative period. During tamponade, the patient will present with decreased chest tube drainage, decreasing pump output despite fluid challenge, and stable or rising filling pressures. This illustration of pump flow versus time demonstrates the typical tamponade scenario. In the early period, a fluid challenge restored pump flow to previous levels. The subsequent decrease in flow was not responsive to fluid boluses. A similar scenario may be encountered if the atrial cannula is obstructed or malpositioned. Patients on BVS support require anticoagulation. Institution anticoagulation therapy may be delayed in the immediate postoperative period until bleeding is under control, but must be instituted no later than 12 to 24 hours postoperatively. Anticoagulation requirements are defined using the activated clotting time, or ACT. ACT must be maintained between 180 and 200 seconds during support. When weaning patients from support, heparin dosage should be increased to bring ACT to 300 seconds. The BVS console is extremely simple to operate and automatically adjusts blood pump beat rate and flow. If the console detects a significant decrease in flow, an audible alarm is sounded, and one of 3 messages is displayed on the console. The low flow alarm sounds whenever flow drops below 1.8 liters per minute in normal operation. Check the dry blood lines for kinking or obstruction. If flow unobstructed, assess the patient for hypovolemia and ensure that the blood pumps are correctly positioned relative to the patient's atria. Once flow exceeds 1.8 liters per minute, the alarm will automatically clear. A low-pressure, low-flow alarm will sound if console detects a decrease in air pressure in the driveline. Check for a disconnected or damaged driveline. The high-pressure, low-flow alarm indicates that either the driveline or one of the bloodlines is kinked or obstructed. An operating and troubleshooting guide is located on the front panel of the console. In addition to safety alarms, the BVS system provides the operator with 3 backup systems in the event of emergency. Battery operation is automatically activated upon loss of AC power and is indicated on the front panel via a battery on message. An intermittent 2-beep signal is sounded to alert the operator. 1 hour portable operating time is provided with fully charged batteries. Whenever the batteries are less than 80% charged and the console is plugged into an AC outlet, a battery charging indicator is displayed. The battery on low alarm activates when the console has less than 10 minutes of portable operating time remaining. The emergency system on alarm sounds if the console microprocessor malfunctions and is unable to determine flow and adjust rate accordingly. In this condition, the console reverts to a fixed beat rate of 35 beats per minute, regardless of atrial drainage. Should the system activate, the patient will continue to be supported, but arrangements should be made to switch to another console. In the event of a total loss of console function, a foot pump is located in the rear compartment of the console. Foot pump is accessed by moving the foot pump handle to the horizontal position and depressing the foot pedal. The pump can be used to manually operate 1 or 2 blood pumps until a replacement console can be obtained. Nursing care of the BVS 5000 patient is not very different from caring for any critically ill patient, though there are some special considerations. If the patient is stable, he or she may be weaned from the ventilator and extubated to reduce the risk of atelectasis. Patient mobility is limited to the bed, but turning the patient from side to side is advised to prevent tissue necrosis. The head of the bed may be raised to allow the patient to sit up. Always assess position of the blood pumps relative to the patient following a position change. Patients frequently hypothermic when they return to the intensive care unit. Traditional methods of warming the patient should be employed. Heat dissipation from the blood lines may be minimized by application of insulating sleeves, which are available from Abiomed. Never apply an external heat source to any portion of the blood pump circuit, as this can increase the risk of thrombus formation. Unlike any other critical situation, ventricular tachycardia or fibrillation in a patient on biventricular support does not result in hemodynamic collapse. The blood pumps operate independent of cardiac rhythm and will continue to support the patient. However, to reduce the risk of myocardial damage, these arrhythmias should be treated per hospital protocol at the earliest opportunity. In the patient receiving only univentricular support, more urgent intervention may be necessary to maintain cardiac output from the unsupported ventricle. Wound care is important to prevent infection. Sterile dressing changes should be made daily. Prophylactic antibiotic therapy can be initiated at the discretion of the physician upon implantation of the cannulae. It should be continued for a minimum of 3 days. The bloodline should be cushioned from direct patient contact with the use of sheepskin. Once the patient recovers, weaning may be initiated. Weaning should only be instituted at the direction of the physician. Indications that the patient may have recovered myocardial function are the presence of output from the native ventricle on the arterial pressure trace, or improvement in ventricular wall motion, visualized by transesophageal echocardiogram. To initiate weaning, open the weaning controls compartment and turn the select knob to the right. The weaning indicator will light. The activate light will blink, and the activate message will appear on the LED display. Press and hold the activate button and turn the select knob to set the desired blood flow. When the activate button is released, the console will reduce flow accordingly. If the reduced flow is not tolerated, simply turn the select knob to the off position. The console will automatically resume full flow. Caring for a BVS patient can be a challenging and very rewarding effort for healthcare professionals. While the course is often complicated, seeing critically ill patients who otherwise would not have survived return to active, productive lives is the ultimate satisfaction. We hope this video series has been helpful in allowing you, the caregiver, to realize this goal.